Hello everyone and very welcome to our webinar today, Urgent PC Masterclass, an option for treatment of OAB. My name is Ilse Citeur and I'm from the library education team. And today we have two presenters. Very welcome Mr. Dudley Robinson and Miss Angie Rentel. Both are from the King's College Hospital in London, UK and speakers for us. Mr. Dudley Robinson is consultant urogynecologist and member of the ICS, and Miss Angie Rantel is lead nurse and nurse cystoscopist, PhD in urogynecology. So the objective of the session today is that you can describe the role of PTNS in the treatment of OAB, and you will get to know the procedure. That means that we have two parts of the session. Part 1 by Dudley is about refractory OAB and PTNS, and part 2 by Angie is the PTNS procedure. And in between we have some time for questions and also at the end. The session of today will be recorded and will be available on the website, and you will receive an email how to access the recording. All people are in listen-only mode, so your microphone is muted by default. And questions you can type in at any time and we will collect all questions and try to answer them all. After the session there's a survey and we would like to hear your opinion. So how to submit your question? Here is the control panel. You can hide or expand. Also there is a raised hand button in case we need it. And here is how you can submit your question. So you just type it in and send it. But before we really begin, we would like to know the audience a little bit better. So we have two poll questions for you. The first one is we would like to know what is your specialty. So I will launch this poll and you can answer it in the screen. So you can see the question and you can just select your answer. For example, urologist, gynecologist, physiotherapist, or maybe you have another specialty. And if you choose other, you might type in the question box what your other specialty is. That would be nice to know. And I'll give just a moment for you to answer. And I see that 69% of the people have voted at this moment. So just wait a few seconds more. It's not coming up. So I'm going to close and share results. And I see that 38% are urologists, 17% gynecologist, 8% physiotherapist, and 38 other. Let me see if I can see other specialties. No, I don't think anyone has shared it. Okay. Thank you all for answering. And now we have the second one. We would like to know how much experience do you have with the PTNS procedure. So here you can select your answer. Maybe you've never used it, just starting, or maybe you consider yourself experienced or very experienced. Let's see. Half of the people have voted. 54%, 57. Okay. I'll share and we'll see. Oh, I see that a lot of people have never used it. And some starting even. Experienced 32% and 9% very experienced. Okay, good to know. So now I'm going to hand over to Mr. Dudley to start the presentation.
Oh, good. Yes. Lovely. Well, thank you very much, Elise, for the kind introduction. And thank you to Library for sponsoring the meeting this evening. On behalf of myself and Angie Rantel, welcome to the Urgent PC Masterclass. And what we're going to do is this evening look at overactive bladder and also look at Urgent PC as an option for the treatment of overactive bladder. For those of you who don't know me, I'm a consultant urogynecologist and I work here at King's College Hospital in South East London. And of course, Ange and I are part of the team of the urogynecologists that work there. And these are my relevant disclosures. So this is the overview of the program for this evening. So following our brief introduction, I'm initially going to cover the management of refractory overactive bladder, and I'll describe exactly what that is. And I'm then going to follow on and talk a little bit about the background and the role of PTNS in clinical practice. After that, I think we're going to take some brief questions, and then I'll hand over to Ange, and she's going to be talking to you a little bit about the tips and tricks, how to do a PTNS procedure, and we'll be showing you a video of that as well. And finally, we'll then finish off with Ange giving an overview of setting up a PTNS service, and also thinking about, for those of you who already use PTNS, is continuing your PTNS service in the post-COVID era. And then finally, joint questions and answers at the end. I'm conscious we have about an hour and a quarter together, so we will be finishing at 8:15 UK time, which is 9:15 Central European time. So to begin with, what I'd like to do is really give an overview of the management of refractory overactive bladder. So overactive bladder is defined by both ICS and IUGA as urinary urgency, usually accompanied by frequency and nocturia, with or without urgency urinary incontinence, in the absence of urinary tract infection or any other obvious pathology. And when we look at this definition, it's important to remember that overactive bladder is a symptomatic diagnosis and not an objective diagnosis. What do we know about overactive bladder? Well, we know it's a prevalent condition. Around 17% of the population in Europe and North America will have symptoms. It may be underdiagnosed and undertreated, and in Europe, only around a third of those patients with overactive bladder symptoms will consult their doctor and receive appropriate treatment. Overactive bladder tends to increase with increasing age, and therefore it represents a significant burden both in primary and secondary healthcare. So what do we mean by the word refractory? So if we look at the English Oxford English Dictionary, you can see refractory is defined as stubborn or unmanageable, resistant to a process or stimulus, and not yielding to treatment. And certainly many of these words are used by my wife in describing me, but when it comes to overactive bladder, it can be a little bit more difficult to know what we mean. And to date, there's been no strict definition of what refractory overactive bladder means, but it generally implies a failure of treatment. Does that mean after the failure of conservative measures? Maybe it means after failure of drug therapy, and if it's after drug therapy, is that after one drug or perhaps two or more drugs? Maybe after failure of botulinum toxin or perhaps neuromodulation. And also, if we're thinking about our patients with refractory overactive bladder, do we need urodynamic investigations to make the diagnosis? So during this first presentation, I'm going to focus on how we should manage refractory overactive bladder. I think we first of all need to make an accurate diagnosis. We need to review our patient's conservative therapy and try to use a holistic approach, thinking about lifestyle intervention as well as conservative measures. When we think about drug therapy, we need to try and tailor that drug therapy to the individual. And by doing that, we may consider alternative routes of administration, perhaps using the oxybutynin patch. We may consider alternative drugs. So we now have antimuscarinic drugs, and we also have meropenem. We may think about using the two of them together, of course, in terms of combination therapy. For those patients who fail on drug, then of course we think about the other management options, including botulinum toxin, neuromodulation, which of course may be posterior tibial nerve stimulation or sacral neuromodulation, and finally, perhaps in a small number of patients, reconstructive surgery. So what about making an accurate diagnosis? This is the initial management algorithm from the International Consultation on Incontinence. And this looks at the initial management of urinary incontinence, perhaps in primary care. So in green, we take a history, incontinence on physical activity, perhaps mixed symptoms, or incontinence with frequency and urgency. In blue, we perform a clinical assessment, physical examination, urinalysis to exclude infection, and also some measure of post-void residual. Based on that, in purple, we can then make a presumed diagnosis of stress urinary incontinence, mixed incontinence, or perhaps overactive bladder with or without urgency incontinence. And based on this presumed or subjective diagnosis, we can then start initial management. And as you can see there, lifestyle intervention and conservative measures. Over on the right-hand side of this slide, of course, we have the complicated incontinence and the red flag symptoms of pain, hematuria, recurrent infections, perhaps previous surgery, and all of these would necessitate immediate referral into secondary care. So, of course, for those of us who look after patients with overactive bladder, we will recognize that many of our patients have many causes of urgency and frequency. So it may be if our patients don't respond to initial therapy, then we need to move on to further investigations. And here we have the more specialized management of urinary incontinence, again from the international consultation. So again, in green, we have symptoms. And in the blue box now, you can see in terms of clinical assessment, we perform urodynamic investigations. And based on this, we then have an objective diagnosis of urodynamic stress incontinence, perhaps true mixed urodynamic incontinence, or detrusor overactivity with or without incontinence. So it's based on this further investigation with urodynamics, we can then move on to our more invasive treatments. So perhaps surgery for those patients with stress incontinence, or in those patients with detrusor overactivity or mixed incontinence, perhaps botulinum toxin, PTNS, or neuromodulation. So it's only after we perform urodynamic studies and we have a cystometrogram trace which demonstrates unstable bladder contractions that we can make a urodynamic diagnosis of detrusor overactivity, defined as a urodynamic observation characterized by involuntary detrusor contractions during the filling phase, which may be spontaneous or provoked. And I think it's important to make this differentiation between overactive bladder and detrusor overactivity because the terms are not synonymous. And as you can see in terms of women, less than half of women with overactive bladder dry have detrusor overactivity and around 60% with overactive bladder wet. So I think when we think about managing and investigating our patients with refractory overactive bladder, then of course it's imperative to make an accurate diagnosis. So when we move on to think about treatments for overactive bladder, of course, we can move from the least invasive, top right, to the most invasive, bottom left. So you can see, I'm sure all of you are very familiar with starting with lifestyle advice, conservative measures with bladder retraining and pelvic floor physiotherapy. Of course, pharmacotherapy remains integral before thinking about the more invasive therapies such as botulinum toxin, posterior tibial nerve stimulation, sacral neuromodulation, and again, in a small number of patients, reconstructive surgery. So when we look at the treatment of overactive bladder, I'm going to base the rest of this lecture on the 6th edition of Incontinence from the International Consultation on Incontinence. And now all of the guidelines I show you are based on the Oxford guidelines in terms of levels of evidence and grades of recommendation. So if we initially look at lifestyle intervention from the ICI, we have a grade A recommendation for weight loss in patients who are overweight, and a grade B recommendation now for caffeine reduction and fluid reduction for those with a high fluid intake. In terms of bladder retraining, this improves central control. It avoids the morbidity or perhaps even mortality which may be associated with drug therapy, and there's good level 1 evidence that bladder retraining is more effective than no treatment. So hence a grade A recommendation that it should be considered as first-line treatment for detrusor overactivity. If we look at pelvic floor muscle training in overactive bladder, there's far fewer studies to suggest that this is as effective as pelvic floor muscle training in stress urinary incontinence. Nevertheless, improvements are seen in most trials for patients with mixed incontinence, and of course there's no evidence of harm. So hence now from the ICI a grade B recommendation that pelvic floor exercises and bladder retraining should be offered as first-line therapy in all patients with mixed or urgency incontinence. However, after lifestyle changes, antimuscarinic agents are currently the most commonly and most widely used therapy for overactive bladder, and antimuscarinics work by reducing the bladder pressure, increasing bladder compliance, raising the volume threshold for micturition, and also reducing the number of uninhibited detrusor contractions. So if we look at the evidence from the 6th International Consultation on Incontinence, you can see all of the antimuscarinic drugs that you would consider using in clinical practice have level 1 evidence with a grade A recommendation. And of course now worldwide we have the introduction of mirabegron that also now has level 1 evidence, grade A recommendation, and in some countries vibegron is now also available. For those of us who use antimuscarinics in clinical practice, I think we've all become more aware of the possible effect in terms of cognitive function. So this is data from Gray, published in 2015, and this is looking at a group of over 3,000 patients over the age of 65, and he looked at the cumulative anticholinergic exposure measured using a total standardized daily dose, and the outcomes were dementia and Alzheimer's disease. As you can imagine, in this age group, the commonest classes of drugs were the tricyclic antidepressants, antihistamines, and also, of course, in terms of bladder medication, the antimuscarinics. And what these authors found was that there was a higher cumulative anticholinergic use was associated with a greater risk of dementia. And if we look at this table, you can see it's actually a dose effect. So for those at the bottom of this table with the highest total standardized daily dose, there was a 50% increased risk in terms of dementia and Alzheimer's disease over a 10-year period. So whilst this doesn't demonstrate cause and effect, it does demonstrate that there's an association or perhaps a relationship. So therefore, many of us have become more aware of anticholinergic load and anticholinergic burden. So at King's, this is one of the commonest scoring categories we use. Over on the left-hand side of this slide, you can see drugs with a low anticholinergic burden, and some of those you may not expect to have an anticholinergic effect. Drugs such as digoxin, codeine, and also hydralazine all have a degree of anticholinergic effect. In the middle, we have drugs with an anticholinergic burden score of 2, and of course over on the right, anticholinergic score of 3, and those are all the bladder drugs that we'd use, such as solifenacin, visitoridine, and tolterodine. So I think this is something we're becoming more aware of, and many of us would now consider using mirabegron in patients with a high anticholinergic burden. We may now also, of course, think about using combination therapy in patients with refractory overactive bladder. So we may consider using an antimuscarinic in addition to mirabegron in patients with overactive bladder. For the urologists in the audience this evening, I'm sure many of you have used an antimuscarinic with tamsulosin as an alpha agonist in men with outflow obstruction. If patients are particularly troubled with nocturia and perhaps nocturnal polyuria, we may consider adding in desmopressin. For those patients with mixed incontinence, we may think about adding in duloxetine, which is a balanced serotonin and noradrenaline reuptake inhibitor. And of course, in our postmenopausal women, we may consider using vaginal estrogens, and there's good evidence to show that they have a synergistic effect in treating overactive bladder. What about our patients who fail on drug therapy? Then, of course, we may think about the more invasive therapies such as botulinum toxin. And these are the results from the EMBARK study, which was a prospective multi-center double-blind placebo-controlled trial in Europe and North America. So this is looking at around 550 patients with overactive bladder. And as you can see, there was a significantly greater reduction in frequency, urgency, and nocturia, as well as urgency incontinence episodes with botulinum toxin as compared to placebo. Of course, this comes at a risk, so higher post-voyage residuals in the Botox arm with a greater need for self-catheterization, and also, interestingly, a greater increased risk of urinary tract infection. For those patients who don't wish to self-catheterize, then of course we may consider posterior tibial nerve stimulation. And of course, I'm going to be talking about that in more detail in the next lecture. And then of course, another alternative would be sacral neuromodulation. So sacral neuromodulation works by altering the somatic afferent inhibition of sensory processing in the spinal cord. One of the earlier studies was reported by Rick Schmidt in 1999, and he looked at 79 patients, at which he reported a dry rate of just under 50% and an improvement rate of around 30%. Philip van Kerbroek looked at long-term follow-up of 100 patients at 5 years and overall found a 60% improvement in terms of urgency and continence and around 40% in terms of frequency. But again, this comes at a cost with revision rates of around 42% at 5 years. A more recent study has been reported in 2018. So this was a large prospective study looking at outcome of sacral neuromodulation at 5 years in 340 subjects, of which 272 had an implant. 90% of these patients were women, and responder in this study was defined as a 50% or greater improvement in symptoms. So if we look at the 5-year success rates, we can see in the intention to treat protocol around 67% and per protocol around 82%. Corresponding improvement in terms of quality of life, but again a significant number of complications. Around 13% of devices failed, 15% of patients complained of pain, and around a fifth of patients had a loss of effect. And ultimately at 5 years, 20% of these patients had the implant explanted. How does sacral neuromodulation compare to botulinum toxin? So this is the 24-month follow-up of the Rosetta trial. And overall, at 24 months, there was no difference between the two treatments in reduction of urgency and continence episodes. At 6 months, botulinum toxin had been shown to be more efficacious, although this difference was lost by 24 months. Interestingly, however, there were still high satisfaction rates with botulinum toxin, although, as you may expect, a higher rate of urinary tract infection and self-catheterization in the botulinum toxin arm as compared to the neuromodulation arm. But again, here you see that 3% of patients in the SNS arm had to have the device revised, and around 10% of devices were removed. And finally, for those patients who fail to improve on all conservative measures, we may think about surgery in our refractory overactive bladder population. And that may take the form of an augmentation clamp cystoplasty, possibly a urinary diversion, and I think now in a vanishingly small number of patients, a detrusor myectomy. So in summary, when we think about the management of our patients with refractory overactive bladder, I think all of us would agree that conservative therapy is indicated as primary treatment. At present, antimuscarinic drugs are the most commonly used drugs, but of course their efficacy is limited by tolerability and long-term persistence. We may be able to tailor antimuscarinic therapy to an individual patient, and also now, of course, we are able to add in a beta-3 agonist such as mirabegron or vibegron to be an effective alternative. Good evidence now from the Synergy trial and the Beside trial that combination therapy has an emerging role prior to the more invasive treatments such as botulinum toxin, posterior tibial nerve stimulation, and of course sacral neuromodulation. And I think all of us on the call this evening would agree that all of these conservative measures should be tried before considering reconstructive surgery. So I'll finish there with the overview of refractory overactive bladder, and what I'm going to do now is focus on one of those treatments, which of course is the focus of our discussion for the rest of the evening. So looking now at the role of posterior tibial nerve stimulation in our patients with refractory overactive bladder. So posterior tibial nerve stimulation was first described by Ed McGuire, who was a urologist from California, in 1983. Subsequently, this was popularized as per-sans or Eurosurge by Marshall Stoller in the United States following this. And then subsequently within Europe, Bart Bellemans described the use of urgent PC, which is the predecessor, of course, of the urgent PC that we're all familiar with using today. So I think looking at the poll, many of us are familiar with using urgent PC, some of us are perhaps less familiar. So let's look at now how urgent PC works before looking at the efficacy data associated with it. So percutaneous tibial nerve stimulation works by stimulating the posterior tibial nerve. This gives feedback into the sacral plexus, and by doing so, neuromodulates the pudendal nerve, and that therefore affects bladder function. If we look at the mode of action in more detail, the posterior tibial nerve is a mixed motor and sensory nerve, and this modulates signals to and from the bladder using the sacral plexus. There tends to be a carryover effect for the pudendal nerve in terms of intravertical stimulation, and this is caused by negative modulation of the excitatory synapses of the micturition reflex. There's a prolonged decrease of synaptic efficacy due to activation of these excitatory synapses, and by doing this, this causes long-term suppression. However, the modulatory effect is prolonged by repeated stimulation, since carryover effect is reversible, and of course this explains why we need the initial treatment and thereafter the maintenance therapy to look after our patients with overactive bladder symptoms. If we look at the overall efficacy rates for PTNS, we can see this is somewhere between 80% dropping down to around 60%, depending on the study that we look at the results of. Now, I think many of us were concerned in the first instance that some of this may purely be placebo effect. So this is answered by this nice study by Peters and colleagues reported in 2010, which is a randomized double-blind trial of PTNS versus sham stimulation in 220 patients with overactive bladder. And you can see that those patients who had active treatment had a much greater effect as compared to those patients in the sham arm, implying this is a true effect that we see from PTNS. So greater overall efficacy in terms of overall bladder symptoms, frequency, urgency, and urgency incontinence. How does PTNS compare with behavioral therapy? So this is a more recent study looking at a prospective randomized trial of 60 women comparing PTNS versus pelvic floor muscle training and electrical stimulation. Overall, there was a significant reduction in frequency, nocturia, and urgency incontinence, but this was greater in the PTNS arm as compared to the pelvic floor muscle training arm. Urgency was only improved in the PTNS arm, and equally there was a greater increase in voided volume in the PTNS arm as compared to the pelvic floor exercises, although there was a similar improvement in quality of life overall. However, ultimately there was a higher satisfaction in the PTNS arm as compared to the pelvic floor exercises arm. What about drug therapy? So how does PTNS compare to pharmacotherapy? So this is a randomized trial of PTNS versus extended release tolterodine in 100 patients with 12-week follow-up. And you can see if we look at those patients who are cured or improved, there was a higher efficacy in those patients with PTNS as compared to a tolterodine extended release. A more recent study has also looked at posterior tibial nerve stimulation versus tolterodine 2 milligrams twice daily. No significant reduction in frequency in either arm, but a similar improvement in health-related quality of life with a significant reduction in urgency and incontinence episodes in both arms. No difference in this small trial of 36 women between groups, but of course fewer adverse effects with PTNS as compared to tolterodine. How does PTNS compare with solifenacin, which is perhaps the most commonly used antimuscarinic drug on the market at the moment? This was a prospective crossover trial of 40 women, and overall there was a significant reduction in frequency, nocturia, and urgency urinary incontinence, but there was a greater reduction in urgency with PTNS, a greater increase in voided volume, and a greater improvement in health-related quality of life. So here, perhaps a greater effect of PTNS as compared to solifenacin. What about long-term efficacy? So this is looking at 32 patients followed up at 6 months and dropping down to 25 at 12 months. And you can see that there was a persistence in efficacy over this time period in terms of frequency, urgency, incontinence, and nocturia. And this was reflected in a significant improvement in terms of quality of life evaluation. We look at a long-term study up, now looking at follow-up over 2 years. Again, it's a relatively small study of only 35 patients, but you'll see an initial improvement in terms of frequency, nocturia, urgency incontinence episodes, and urgency symptoms, and this was maintained over the 24-month period. So how does PTNS compare to other invasive treatments? So this is a more recent study comparing PTNS to botulinum toxin. And overall, there was a significant improvement with botulinum toxin at 9 months in terms of overactive bladder symptom severity, urgency scores, quality of life, and urodynamic outcomes. And whilst there was an initial significant improvement in the PTNS arm in all outcome measures, this wasn't sustained out to 9 months. But bear in mind, in terms of Botox, self-catheterization rate of around 6%, and again, 6% of patients had recurrent urinary tract infections, whereas those patients who had posterior tibial nerve stimulation had no significant adverse effects. So if we look at a recent systematic review from Claire Burton and her group, you can see this is looking at the effectiveness of PTNS in overactive bladder, initial success rates of up to 82%, and when they looked at 4 randomized control trials and 2 randomized control trials looking at antimuscarinic therapy, there was a pooled subjective success rate of around 60%, and this was similar to the objective success rate of 60% as well. If we look at a recent Cochrane review, this is now looking at anticholinergic drugs versus non-drug therapy in 23 trials, which are around 3,500 participants. As you can imagine, there was greater improvement with drug as compared to bladder retraining. Drug therapy and bladder retraining were better than bladder retraining alone. Interestingly, drug therapy and bladder retraining were not better than drug therapy alone, which I found particularly surprising. And it was reassuring to find that posterior tibial nerve stimulation was better than drug therapy alone. So I think reassuring evidence from this Cochrane review. Where are we now in terms of the ICI recommendations? So a grade C recommendation for PTNS for women with overactive bladder and urgency urinary incontinence may be more effective than no active treatment. And a grade B recommendation that there's no significant difference between posterior tibial nerve stimulation and tolterodine. Both have been shown to improve quality of life. Posterior tibial nerve stimulation is associated with fewer and less bothersome adverse effects when compared to drug therapy, and it may be used in combination with other overactive bladder treatments. So finally, what do our patients want? And this is a UK telephone-based preference study looking at 140 overactive bladder patients, of which 2/3 were women. Overall, around 90% had experience of drug therapy only, and then they were asked what other treatments they'd like to consider using best to worst scaling. As you can see, 57% of patients opted for posterior tibial nerve stimulation, around 1/3 for sacral neuromodulation, and interestingly, only 1 in 10 would have chosen botulinum toxin. So I think reassuring evidence from the efficacy data that PTNS works, from the safety data that there's no adverse long-term effects, and from this study that perhaps it's something that our patients would like to consider. So I'll finish with a picture of our multidisciplinary team from King's, and I will firstly hand back to Elise, and I think if we have any urgent questions, I would of course be delighted to take those.
Yes, thank you.
Sorry, thank you, and good evening, everybody. Dudley, we've had one question in for you, and that's around the sacral nerve stimulation. And you were talking about one of the challenges has been around revision rates. Do you think that the revision rate will be lower with the newer generation implants that are coming out now?
I mean, it was interesting, wasn't it? If you looked at those 2 studies, the revision rate was much higher in Philip van Kerbroek's original study it's lower. We're using the new devices. So the new there's two devices now on the market from Medtronic and also from Axonics. Axonics device is smaller, so that may be associated with less pain and less complications, and is also associated with a longer battery life as well. So I would hope that perhaps, now that we have alternative agents on the market, then perhaps CT and SNS will be better.
Thank you. And I'd like to encourage everyone, please do put your questions into the question box for us. We haven't had any other questions come through yet.
No.
So should we start talking about the procedure?
Yeah, let's do that.
Absolutely.
I'll hand over.
We can have joint questions.
Yeah.
Good evening, everyone. And I am going to be sharing with you to begin with about how you perform the procedure. Here are my disclosures. And what I'm hoping to cover with you over the next 15 minutes or so is thinking about the patient selection that we'd be considering for PTNS and the assessments that we should be undertaking prior to starting. We're going to have a look at the procedure and think about some tips and tricks. And after that, I'm then going to show you a video. And then finally, we're going to look to suggest how to set up and deliver a PTNS service and look at challenges. So when we think about PTNS, we need to think about the contraindications as to who can and can't have PTNS. And there are some complete contraindications and some that you may consider. So the ones that are definite no's, these people are not suitable for PTNS, are those that have a pacemaker inserted or any form of implanted defibrillator, women who are pregnant or planning to become pregnant imminently. We also need to be careful in our consideration about those that have cardiac history or neurological damage or a tendency towards excessive bleeding. And in these cases, particularly for those with a cardiac history, it may be worth discussing with their cardiologist whether they are concerned about any potential issues. And for those with excessive bleeding, it may be worth to do a trial of a needle placement and see what happens. The final one on the list is related to those with significant peripheral edema. And this is something that if someone has significantly swollen ankles and you're trying to put the lead placement in, it may be that you can't get near enough to the tibial nerve to actively stimulate it appropriately. In these cases, we may be able to try certain things, such as changing the timing of their appointment, giving them a diuretic a couple of hours before their appointment, or trying things to reduce the edema prior to their stimulation. But if you put the needle in and you can't get any reaction from the stimulation, we may have to think about sending them for appropriate treatment for their edema before we think about anything else. When we're looking at our initial assessment, following assessment of the contraindications and suitability for PTNS, we then need to think about how we're going to counsel the patients about the length of treatment. So the fact that they need to come in and have a hot treatment for 30 minutes every week for 12 weeks for their initial course of therapy, and then the need for top-ups. Now, for some patients, that may be every couple of weeks or every month for a while, or even for some, it may be every 2 or 3 or 4 months that they have a top-up. But unless they have continual top-ups, they don't have the prolonged carryover effect, so the treatment efficacy wanes. We need to let them know how to manage their expectations. We know from the studies that there's a 60 to 80% improvement rate in symptoms. So we need to be explaining to the patients that this is looking to improve their symptoms, but it may not completely resolve their symptoms. And often, as Dudley has already said, we're using it in conjunction with all of the standard lifestyle and conservative measures, but we may also be using it in combination with drug therapy. We need to let the patients know how we're going to monitor the effectiveness of treatment, particularly for something where changes are happening slowly over a prolonged period of time. We need to monitor with objective and subjective assessments throughout treatment. And so I'll tell you what we do in a little while. As well as the risks of continuing therapy with all informed consent and decision making, we need to know that the patients are aware of the alternatives, like Dudley has spoken you through, and the potential risks and side effects of treatment. So when we're thinking about risks and side effects, that actually they're very generally low rate of risks and they're very transient. Sometimes patients can report some slight discomfort at the site of needle insertion or some slight redness or inflammation at the needle insertion site. Some people have reported some numbness in their toes, and for some people they may not notice any improvement in their symptoms. But when we're thinking about what benefits we're hoping for, we're looking to improve their overactive bladder symptoms, and we would be able to see that as an objective change in OAB scores. And we're looking to improve their quality of life, which again can be assessed objectively with a score. This is just an example of the pro forma that we've developed at King's to help us when we're doing our initial assessment to work through all our contraindications, our history, and make sure that we've discussed all the points of how what we're going to use and how we're doing it. So how do we perform the procedure? When you're doing the procedure, you have your urgent PC stimulator, and then you have your lead set, and you're going to use a new lead set for each patient per treatment. To prepare the patient, you're going to get them sitting or lying comfortably on a couch or in a recliner chair in a comfortable position, because they're going to be there for the next half an hour. And we need to make sure that the inner aspect of the ankle is accessible. Now, the only thing that I would just add here that I didn't say previously, often it doesn't matter which ankle you use, and you can alternate on each treatment. However, I tend to avoid, if for any reason a patient has any metal pins and plates in one ankle, I tend to avoid that ankle. And you also need to make sure that your stimulator battery is functioning and full. When we're thinking about inserting the needle electrode, you're going to be locating the insertion site. So you're going to be looking to the medial malleolus, and you're going to be going 5 centimetres or approximately 3 finger breadths up the leg, and then you're going to be rotating and moving 2 finger breadths or about 2 centimetres posterior to the tibia. You're going to use an alcohol swab to prepare the skin around the area, and when you are using the swabs, it generally takes about 30 to 60 seconds for it to dry around. You're then going to be placing the needle and the electrode guide tube in the area that you've located at a 45 to 60 degree angle to the skin running up the leg. There's a little pink stop plug in the top of the guide tube that you're going to remove, and you're going to gently tap the top of the needle into the guide tube so that it just pierces the skin. You're then going to advance the needle gently using a rotating motion at that 45 to 60 degree angle up the leg until about 0.5 to 1 centimetre of the needle is left exposed. We're then going to attach the lead wire to the stimulator, place the adhesive surface electrode on the foot near the needle aspect of the calcaneus on the same leg that the needle's in, and you're then going to hook the needle electrode clip around the needle electrode. Once all the equipment is in place, you're then going to start working on the settings for therapy. So you're going to turn the stimulator on and press the test button. And we use the plus and minus buttons to change, increase or decrease the current. We're going to use the plus button to slowly increase the current, and whilst you're doing this, you're observing for a response and you're asking the patient to tell you what they're feeling. Because for some patients, you may get a motor response to treatment. So it may be a flexion or a fanning of the toes. You may get an extension of the entire foot. For some patients, they may get a sensory feeling. So they get a feeling of tingling under their foot or a feeling of heaviness or numbness. For some people, it may run into their heel or into their toes. For other patients, it may run up their legs. So we're asking and we're wanting to see and get a response, be it sensory or motor. The stimulator can be increased up to a maximum current reading of 19. And often, the higher that you go on the stimulation, this is just a sign of the further away that you are from the tibial nerve. So it doesn't mean that they're not good treatment. We don't want the patients to be uncomfortable during treatment. They need to be able to tolerate it, but they need to have had a response. So when we've had that motor or sensory response, then we keep it where the patient can tolerate it, and you press the green button to set treatment for 30 minutes of therapy. It is completely normal that patients become acclimatized to their sensation during treatment, and within 5, 10 or 15 minutes of the treatment, they may no longer have the sensory response. That does not mean that it's not still working for them. When the 30 minutes of treatment is finished, you're going to turn off the stimulator, release the needle electrode clip, and remove the electrode whilst gently stretching the skin above it. And if there's any bleeding at the site, then you can just apply some slight pressure to it. We remove the surface electrode, disconnect the lead, and dispose of the needle and the lead set in your appropriate sharp spin. And then you repeat this process for 12 weekly sessions for their initial course. So this is the point where I'm going to hand back to Elsa to show the video demonstration of what I've just described.
Yes.
The Urgent PC neuromodulation system is a low-risk, non-surgical treatment for overactive bladder. The Urgent PC system is a combination of the Urgent PC stimulator, which delivers electrical impulses, the needle electrode, which transfers the electrical impulses to the tibial nerve, and the lead wire, which connects the adhesive surface electrode, needle electrode, and stimulator. During the treatment, the patient sits with their foot elevated and the needle electrode in their ankle while receiving electric stimulation for 30 minutes. Impulses from the stimulator travel up the tibial nerve along the leg to the nerves in the pelvis that control bladder function. The clinician uses their fingers to locate the right place to insert the needle electrode near the ankle. It is approximately 3 fingers above the middle of the ankle bone and 1 finger back from the tibia. The clinician uses a plastic guide tube to mark the insertion spot and then cleans the insertion area with an alcohol pad. Patients may feel the tap of the needle as it pierces the skin and is inserted. The clinician attaches the adhesive surface electrode to the bottom of the foot, which acts as a grounding pad for the electrical current, and then attaches the needle electrode clip to the needle electrode. The clinician will turn on the stimulator and slowly increase the impulses. They will ask what the patient is feeling and watch for involuntary toe movement. Toes may flex or fan in response to the stimulation, or the patient may feel sensation in the heel, bottom of the foot, or up the leg. If there is no response, the clinician may adjust the needle or stimulator or try the other ankle. The patient sits comfortably for 30 minutes during their treatment session. At the end of the treatment, The clinician will turn off the stimulator and remove the needle electrode. The patient is free to resume normal activities.
Yes, so I'm handing back.
Fabulous, thank you very much. So that's the procedure. It's very straightforward. It's once you've had practice with putting the needles in and build up your confidence, it's very easy. So let's think about how you set up a service and how you integrate it into practice. And to begin with, whenever we're thinking about setting up a practice or setting up a new service, you have to do an assessment of your current service and set a vision for it. So what is it you're wanting to change or achieve? How do you envisage your service will improve the quality of care or the outcomes for patients with overactive bladder? And what do you intend the service to look like? So it's useful thinking about, what are we doing now and how well are we doing it? What will the future demand be? Are there any gaps in our service? And how will a PTNS service help to fill those gaps? And what would we like that service to look like? You need to make sure that you engage your key stakeholders in your local service. So not only your nursing managers, your lead clinician, your divisional management and the departmental management, but the finance and the procurement team, patient and public involvement. And if you work in a health service where services are commissioned, your local commissioners as well, or insurance companies. When you're trying to look at securing funding and approval, I recognise that this is very challenging to give you the most appropriate information, because this is an international forum that we're using today. So a lot of this may not be appropriate in your own health service, but some of these will help you. So it's about evaluating the service and the environment that you have. So what are the current issues and challenges in your service? And what's the current and potential future capacity and demand for services? You need to think about the benefits of the proposed service and model of care. So what, how, where and who will deliver the service? And what are going to be the opportunities and benefits provided by a new PTNS service? You need to think from a financial point of view about what income do you need, what are the startup and running costs of running the service, what's the likely profit within the first 3 years of setting up the service, and what's the cost benefit of the new model compared to what we're currently providing. You need to do a risk assessment of the potential areas of risk versus benefit for bringing in a PTNS service, and what measures you can take to avoid that risk, and set up key milestones for service setup and expansion, and set timescales for the milestones and allocation of responsibility for each activity. When you're writing a business case, as a minimum, you have to establish your key demographics, the prevalence of the issue, the incidence, and proof of the unmet need. And the projections of the increase in demand. We know that we have an increasingly ageing population, and the overactive bladder is far more prevalent the older we become. Therefore, by its nature, we would be expecting to see far more patients living longer, developing refractory overactive bladder symptoms that may require PTNS. You need to think about your current outcome measures, patient satisfaction, and the current weaknesses and lack of capacity in your current service that you're trying to improve and resolve. You need to think about the resources that you're going to need. Who is going to staff this? In many countries where there are clinical nurse specialist roles, this is a service that's completely run by the nurses. There's a lot of physiotherapists who also perform other types of electrical stim that are also providing this. But in certain countries, it's the medics that are running this if they don't have the specialist nurses and allied health professionals around them. You need to think about the clinical space to manage this. waiting area and reception rooms. You need to think about the consumables that are going to be needed and the equipment for this. And if you are seeing patients every week for 12 weeks in a row plus regular top-ups, there's going to be an element of administrative support, appointment booking that you're going to need support with. There are lots of different ways that people around the world run their PTNS service, and there is no one right way because it depends on what's right for your service. Some people run a dedicated PTNS clinic that's staffed by a particular group of people. Other people run ad hoc appointments within their normal service, but you then have to make sure that you allow for at least a 30-minute appointment in order to have the therapy. Pre-COVID, people often used to run group therapies for PTNS. So they'd have a whole day room with recliners that you could have multiple patients on treatment all at one time, and that made it far more time effective from a point of view of staffing. However, that's not something for many services we're quite back to. So you're then at one-to-one appointments, and so you need to have a number of rooms to be able to run those appointments concurrently. Some people start patients in batches of their 12 weeks every 3 months, whereas other people start ad hoc as they're able to. Some people have overlapping appointments. You need to work out what works for your environment, your clinical space, and your staffing. But you must make sure that you have appropriate access to an MDT. We know particularly in the UK, the recommendation set by NICE is any patient having tibial nerve stimulation has to have been assessed and discussed at a multidisciplinary team meeting prior to starting therapy. From a continuity of service, you can't just have one person that can perform that therapy. Who's going to cover if they goes off sick or on holiday? So you need to make sure you have appropriate number of staff trained. And when you're thinking about the top-up sessions following the course of therapy, do you book set appointments 4 weeks later, 8 weeks later, or do you make it that patients can call up and access an appointment in a short space of time when their symptoms start to recur? From a health and safety point of view, you need to make sure in the area you have appropriate sharps disposals and trust procedures for needle stick injury, decontamination, emergency planning and recovery area. I have never, with a patient on treatment, had anyone become faint, become unwell, or have anything to worry about. However, I once had a patient faint on me when she wasn't even a patient. This was during a teaching session when people were practicing on each other, and one person fainted when they had the needle inserted. So you need to have a setup for emergency planning and recovering just in case something was to happen, although I've never had it in practice during my PTNS clinics for the past 13 years that I've been running them. You need to think about your equipment and how many stimulators you're going to have, because obviously depending on the number of patients that you want to treat at one time, you'll need to consider that, and how you get your stock of consumables. And then your training. Yes, you can have an official study day or on-the-job training, but are you going to have all your initial procedures performed with supervision, someone who's already qualified to do that? So you need to think about your training. You should also have an appropriate treatment protocol with the indications and contraindications, potential complications, consent and accountability, equipment, patient preparation, how you perform the procedure, what you do post-procedure, what your follow-up is, and what documentation you should do. And this is true for any procedure we perform within practice. And you also need to think about what patient information, leaflets, diaries, questionnaires, consent forms that you may be using. In my practice, because we don't like to reinvent the wheel, we know that there are great information leaflets on the International Urogynae Association website, and so that's yourpelvicfloor.org, and these are available in multiple different languages. So they're really, this is what I use in practice rather than developing our own. Finally, to think about audit and evaluation and how you're going to assess the patients having treatment. In my practice, we look to use objective and subjective methods. So pre-treatment and at the end of treatment, we ask them to complete frequency volume charts. So we can look for objective reduction in urgency scores, frequency, but we also use subjective measures as well, so quality of life scores and patient satisfaction. So we use the King's Health Questionnaire, which is also the ICIQ FLUX Qual, to assess for quality of life pre and post treatment as well. There have been challenges post-COVID. During COVID, we weren't able to provide any PTNS therapy because we weren't allowed to bring patients into hospital for non-emergency reasons. And we continue to have limitations on footfall. When we're looking at, our focus has been on clearing backlogs of diagnostics rather than providing treatments. And there's also questions about, there's a lot of staff now with recovery about the health and well-being, with people having lots of holiday to use and not quite back to full running. So one of the things we've been working on is trying to have other ways to get support and advice to patients who have been added to a waiting list for PTNS, and what we can do to help them in the interim. One of the challenges we've had since is the lack of clarity and constantly changing advice on pathways and risk assessments. And for many patients, there has been an increased anxiety and fear about coming into the hospital every week for 12 weeks and the potential risks that that may entail. Yet there's also those frustrations with not being able to access the services like they used to. Just out of interest, one of the other issues that we're seeing is for the patients that we haven't been able to treat for some time, or that have been waiting to come in, as we're starting to bring them through, many of them now have additional complications or other health concerns, and actually lots of these patients are having to be reassessed for suitability and re-reviewing all of the other conservative therapies along the way. I'd be interested to hear if other people are seeing the same things. So I am going to stop talking there and happy to take any questions that we may have.
Yes, so if the audience has questions, please let us know and send them in the control panel. And there have been submitted some questions, and I'm going to send them.
Lovely. So thank you very much, Ange, for a lovely overview. And I hope you all enjoyed the video as well. I think we had some problems seeing it, but I hope everyone else saw it. So we've got some questions coming in, which is great. The first question, this is sort of maybe slightly outside the box. When you initially assess patients, do you also ask if they've got problems with fecal incontinence, as this often coexists with OAB?
So whenever we're assessing our OAB patients, we are always asking about bowel conditions. We know that about a third of patients with lower urinary tract symptoms will also have some sort of concomitant bowel condition. Often with the OAB patients, it's actually more along the lines of chronic constipation rather than fecal incontinence. So we would always be asking for bowel symptoms. Now, there is also evidence for the use of PTNS for bowel problems. Some people are using it for constipation, some for fecal incontinence. So if we do have a patient that has bowel symptoms, we would always be advising them that they may find that there is an improvement or a change in that. But again, we would potentially be working alongside our colorectal colleagues as well, because we'd want to make sure that we're not that they're happy with that approach from treatment, rather than, and it's not going to cause any issues with any other treatment they were potentially planning.
But I think there is reasonable evidence, isn't there, of efficacy for fecal incontinence, and I know a lot of centres do use it. So I know you like this question. This is right up your street. So the next question is, do you have set guidelines to follow in terms of PTNS top-up following the initial 12-week phase, or do you let your patients be in control and tell you when they need a top-up?
So we don't have set guidelines. In a lot of the trials, there have been a variety of different top-up regimes used. Some have followed them up every 2 weeks for a period of time, every 4 weeks. And we have never been able to sustain those sorts of levels of top-ups in our service. We just don't have capacity. So once we've finished a course of therapy, we would generally do someone's first top-up at around the 8-week mark. And we would do their first top-up then and see how things have been. I have patients that have top-ups from anywhere between every 6 weeks to every 6 months. And so we get guided by what the women say. For the patients that I've had that have been having PTNS for me with maybe 6, 7, 8 years, most of them are on a set, yeah, I want to see you again in 3 months, I want to see you in 4 months' time, and they work that way, and we pre-book it at that point. For the newer patients, we adjust it purely based on their symptoms and when they feel they start to recur, so that we can then individualise the pathway to them.
Thank you, Ange. So the next question, I think, is probably more for me. How long would you use medications prior to diagnosing refractory overactive bladder? And the problem with this is that, as I said, there's no definition. I think I would generally give them the initial drug, which is likely to be an antimuscarinic. If they didn't respond well to that, or they had adverse events, I may switch to mirabegron, or maybe wherever you are, you may have vibegron. If efficacy was a problem, I may switch to combination therapy, and after combination therapy fails, I think I would then consider that to be refractory overactive bladder. So I think probably an antimuscarinic, a beta-3, combination therapy, and then failure on that, I would say refractory. Okay, so back over to Ange. After lockdown, we received new contraindications to PTNS from Laborie, and it's been presented by you. And is a contraindication any metal in the body? So if someone's got a metal implant, is it a contraindication?
No, metal implants somewhere in the body aren't a contraindication. The only implants that are contraindications are pacemakers and defibrillators, internal defibrillators. So I have many patients that might have pins or plates in their legs. I just tend to avoid the leg that they have all that in. And my theory is pure, if they've had a lot of surgery and had pins and plates in that leg, there's going to be scarring, there's potentially going to be disruption to the normal nervous pathways anyway because of all of that surgery. And so my question is whether it will actually be as effective. Therefore, I've always just avoided it and used the other leg.
This is a good question. In regard to counselling for PTNS, when do you tell the patients they'll notice any change in their symptoms?
So I always generally advise them that I don't expect that they will start to see any benefit until about halfway through treatment. So when we're doing our counselling, we get them to, like I said, we use bladder diaries pre-treatment and quality of life questionnaires pre-treatment. We actually, at 6 weeks of treatment, get them to fill out another bladder diary so we can start to see if there are any changes, because we would expect to see some changes about 6 weeks, and then repeat bladder diaries and quality of life questionnaires at week 12. However, if we've had a patient who at week 9 still says they have had absolutely no change in improvement or no difference in symptoms, and objectively we've seen that their diaries are still the same, we probably wouldn't continue with the last couple of weeks of therapy, and we would count that as a failed treatment. But that's, you know, probably over the past 12 years, I've probably had 3 people that we've stopped at the week 9 mark because they've just had absolutely no change in symptoms. So it's not very common, but yeah, 6 weeks, I'd say, to start noticing differences.
Perfect, thank you. So the next question is, once you've completed your 12 weeks and then you're on maintenance, is there a maximum number of maintenance sessions, or does it just go on forever and ever and ever?
That there's no long, you know, I'm not aware of any data that follows up these patients over 10 years or more. For a lot of people, we know if you look at all of the other treatment options for overactive bladder, there tends to be a lot of people that you lose to therapy over 5 to 10 years. You know, the Botox studies, there's a group of people that don't come back, the medications. And if you actually look at the prevalence studies, there seems to be a group of patients who maybe are bothered by symptoms for a while. Potentially they get treated, they're happy, they then go away for a while and don't sort of are managing things, and then potentially come back many years later. So given that the disease itself has sort of these peaks and troughs in prevalence, I don't know is the answer. For the patients, if they are happy with things, they may well be on it long term. If for some reason, you know, years down the line, they decide that it doesn't fit their lifestyle anymore, they want to, their symptoms have deteriorated, their symptoms have changed, they may choose to go for an alternative therapy. But I don't know the specifics, or I'm not aware of any research that quantifies that.
I don't think there is. And of course, overactive bladder symptoms tend to go up and down as well, don't they? We've got a question from Sasha. How do you select patients for top-up? Do you use anything objective, or is it just subjective based on their symptoms?
Subjective based on symptoms. So once we've done the initial therapy and the initial courses and their assessments there, but any top-ups we do purely based on symptom recurrence, because again it varies amongst the time of year. We find in the winter time when it's cold, people often want to come for top-ups a bit sooner. In the summertime when it's nice, they go a bit longer. So we go purely by symptoms and when it's starting to become bothersome again.
What about those patients who have refractory overactive bladder? They're on their antimuscarinic medication. Do you ask them to continue that while they start the PTNS for a period of time? And if so, how long?
So for most of our women that are refractory, we give them 3 options when they start treatment, because often the reason they're coming to this is because medication hasn't gotten rid of all of their symptoms. So we give them one option that they can stay on the antimuscarinics or the beta-3, and they have this in combination with it. And so we're looking to take the edge off the symptoms that drug therapy isn't managing. And so we say, well, you can stay on it long term and see if between the combination you get the symptom resolution that you want. For some women,
and I think there is evidence to show that as well, isn't there, from some of the studies that you can combine it with other therapies?
Completely. For some women, they want to not take medication every day. So we would tell them to have the course of treatment first, and then we'd look to wean down their medication once they've completed treatment and see how things go, with the knowledge that they can always restart at the end. But again, we don't want women to stop medication until they're starting to get some benefit from the treatment. And if that's going to take at least halfway through treatment to start to get benefits, we'd say let's treat you and then let's wean you off at the other end.
I'm conscious that we're sort of on time, but I've got three questions left. So quick answers. Would you start PTNS without urodynamics?
Personally, in our own practice, no. We want to rule out, patients coming for PTNS would have had urodynamics and most likely would have had a flexible cystoscopy or sort of other things to rule out other underlying problems before we would consider that for management of refractory OAB.
And I guess, remember here we're talking about refractory overactive bladder as well, aren't we? So we're not talking about primary therapy. And then how would you tailor the strength of the stimulation? So how do you manage what number do you go up to?
So it goes by the patient's sensation. So once I've had either a motor or a sensory response, I will then say to the patient, okay, so I know I'm stimulating the nerve because we've had a response. If you go up a level and it becomes uncomfortable, that's not going to, you don't want the patient uncomfortable. So you want to know that you've had a response, but you don't need to keep going up and up and up until you see where they can tolerate it. There's no evidence to say that that equates to better work. The fact is you want to know that you're stimulating the right place and that you're getting the results. So if I get that response, I will then try one up and see if it's tolerable. If it's fine, I'll set the therapy there. If it's not, I'll reduce it down. But the biggest thing is advising the patient that actually the number you don't go up to, a higher number on the stim, doesn't equate to better outcomes. It just means I'm further away from the nerve. So again, if different people do it, they'll often get different results each time. And it just depends on the size of the individual person's fingers and exactly how far away from the nerve they are that's stimulating.
And the final question, I think I can answer on behalf of Ange. What's the proportion of males versus female in our practice? We urogynecologists, so we only have female patients, I'm afraid. But of course, it is a licensed treatment for men as well. And just off the cuff, Ange, do you know what the efficacy data is like in men versus women? Or
I'm afraid I don't know.
So I think we've dealt with all the questions. I'd like to thank Ange for, as always, a fantastic talk and a great video. I'd like to thank Elise and the team from Laborie for looking after us this evening, for sponsoring the session. For all of you, I hope you found it useful. Thank you very much to all of you who've asked questions tonight. I'm sure if there's any more questions you have, we'd be delighted to answer them, or maybe the team from Laborie could as well. So with that in mind, thank you for attending this evening. I hope you found it useful. Thank you to Laborie for sponsoring, and have a good evening.
Yes, thank you both for this session, and thank you audience for the interesting questions. And here you see some other educational opportunities. So soon we have the introduction to flexible cystoscopy, and also we have a webinar on the benefits of in-office urethral broking with microplastic. So thank you everyone, and have a nice evening. See you during the next webinar. Bye bye everyone.